discuss about the different types of shock. Before that, what is shock? Shock is the systematic state of low tissue perfusion that is inadequate for normal cellular respiration. What does that mean? Normally, in tissues, there will be oxygen delivered. As a result, there will be aerobic metabolism and carbon dioxide will be produced. Suppose if there is low tissue perfusion, the delivery of the oxygen will be less. As a result, instead of aerobic metabolism, there will be anaerobic metabolism, and instead of carbon dioxide, lactic acid will be produced. So this will result in lactic acidosis, metabolic acidosis, and finally all the glucose will be used up by anaerobic respiration, and this will result in loss of function of the sodium potassium ATPase of the cell, and finally resulting in cell death. So does shock means hypotension always? No. By the current definition, it doesn't mean that there should be always hypotension. There should be less tissue perfusion. So at one end of the spectrum, there will be a mild lactic acidosis and increased heart rate. And on the other end of the spectrum, there will be anuria, hypotension, coma, and labored breathing. So we can divide this spectrum into compensated shock, mild shock, moderate shock, and severe shock. So what are the organs which are affected in severe shock? We can see the organs are kidney, which result in anuria, heart, hypotension, brain, coma, and lung, which result in labored breathing. So in moderate shock, severe shock, all these organs shut down. In moderate shock, all these organs are affected, but to a lesser extent. In kidney, there will be decreased urine output. In heart, there will be mild hypotension. In lungs, there will be increased respiratory rate. And in brain, the patient will be a bit drowsy. In mild shock, the lung and the brain is affected. Again, there will be increased respiratory rate and there will be a mild anxiety. In case of the decompensated, in case of all these stages of shock, there will be lactic acidosis, which will be progressively increasing as the severity of the shock increases, and there will be increased heart rate in all the decompensated, mild, moderate, and severe shocks. Now, how will we monitor the shock? For that, the minimum requirement is we should have an ECG, a pulse oximetry, blood pressure monitoring. So that means we should have a multi-para and the patient should be admitted to ICU. Urine output should be monitored. That means the patient should be catheterized and serum lactate should be measured. So what is the advantage of monitoring? We will know that we will be able to understand that the patient is going to mild to moderate, moderate to severe, or the patient is improving from severe to moderate or moderate to mild. That we can understand by monitoring the shock. Now, how does this shock happen? How does this decreased tissue perfusion and anaerobic metabolism happen? The causes are hypovolemia, cardiogenic shock, obstructive shock, or distributive shock. To understand this point, let me take you to a garden pump where there is a water tank, a motor, and a pipe which sprays the water. So the water tank corresponds to the preload, and this is because it is a heart and there is a lung, there will be a lung, and from lung to the motor or the heart, left ventricle, it will be pulmonary circulation, and the motor is the heart or the left ventricle, and next is the systemic vasculature. When this all will give the tissue perfusion. So in case of hypovolemic shock, there is no adequate blood. There will be decreased or absent preload. So the problems with the causes of hypovolemic shock are hemorrhage, gastrointestinal losses, third spacing of the fluid, and burns where the fluid is going out through the skin. Next is the cardiogenic shock. Here the motor is not pumping. The left ventricle of the heart is not working, so that the blood does not go distally adequately. So the causes of cardiogenic shock are myocardial infarction, bradycardia, the heart rate problem, valvular heart disease, heart blocks, and end-stage heart failure. Next is the obstructive shock. Here there is adequate fluid, adequate volume, but the blood is not coming to the left ventricle for pumping. There is block in between the right atrium and the left ventricle. So that is the obstructive shock. The causes of obstructive shock are pulmonary embolism, tension pneumothorax. Again, the filling of the left atrium and left ventricle is prevented by tension pneumothorax. Or pericardial tamponade. Again, the left atrial relaxation and the left ventricle filling is prevented by the pericardial tamponade. There is adequate fluid, their cardiac contractility is normal, peripheral vascular circulation is also normal, but there will be inadequate filling of the left atria and left ventricle, resulting in obstructive shock. And finally, it is a distributive shock. Here when we see the picture, it is seen that all the pipes are dilated. The walls of the pipe are not thick. The walls of the pipe are loose. That means the vasculature, the systemic, the pulmonary, all the vasculature has lost its tone. It can be either due to decreased sympathetic output as seen in neurogenic shock, or it can be due to the effect of endotoxins as seen in the septic shock. So examples of distributive shock are sepsis, anaphylaxis and neurogenic shock. So these are the different types of shock: hypovolemic shock, cardiogenic shock, obstructive shock and the distributive shock. Don't expect these 4 shocks to occur typically in a textbook manner. There can be mixed shocks. For example, in a case of perforation peritonitis, there will be third space fluid loss in the abdomen, and there can be a systemic sepsis for this patient, and so that patient will have an element of hypovolemic shock and there will be an element of septic shock. Another example is an endocrine shock. For example, in Addisonian crisis, there will be a component of hypovolemia, a component of decreased myocardial contractility which result in a cardiogenic shock, and there will be a decreased vascular tone which result in a distributive shock. Another example is a post-operative patient with pulmonary thromboembolism. There will be an element of hypovolemia and there will be an element of obstructive shock. So the shock can occur in combination as mixed shocks. So it is our work to identify which all combinations of shock are present in a patient.